Good evening, or good morning, or good afternoon, wherever you are. Welcome to the 7th webinar of the BASH 2021 webinar series. My name is Fayaz Ahmed, and I'm a neurologist in Hull and East Yorkshire Hospital NHS Trust. And I'm also the educational officer for the British Association for the Study of Headache. I would like to thank you all for attending the webinar, the 7th webinar of the series. I'm very grateful to the panelists, the speakers, and the members of the BASH Council, particularly the chair of the BASH, Mark Wetherill, who helped me organizing the event. I would like to thank our sponsor, and here I would like to share with you the slide. So we have Allergan, Teva, Lilly, and Lundbeck, who's given us unrestricted educational grants to organize these webinars, particularly in the COVID pandemic when we can't meet face-to-face. The good news is that all these webinars are approved for external CME points by the Royal College of Physicians, and you can see the code 1334431. You are able to watch the program live on the Facebook and live through the Zoom, but you will be able to see all the previous webinars and the current webinar on the BASH Education UK YouTube channel, and the link of that is given on the slide. So today we have the Birmingham team who's going to talk about idiopathic intracranial hypertension. Idiopathic intracranial hypertension has been the focus of research over the last decade, and that's thanks to the Birmingham team, who has done a lot of work and published extensively on the subject. We now know more about it than we did about 10 years ago. The next webinar we would have in August, which would be the childhood headaches. And we would have the pleasure of the company of Prabhakar, Ishaq, Abu Arafe, and Kay Kennis from primary care, who would be able to join us for that session. I'll stop sharing my screen now. So I would like to start the program with the first speaker, Alex Sinclair. This is a recording, but Alex will be joining us in the question answer session at the end of all the three talks. Alex is a professor of neurology at the University of Birmingham. She's done a lot of work on IIH along with other members of the team, which are all here this evening. Alex has been affiliated as a board member of the International Headache Society, British Association for the Study of Headache, European Headache Federation, and the British Association, Association of British Neurologists. She's going to talk about the update on the idiopathic intracranial hypertension, and I would start with her talk by sharing on my screen.
Good evening. Well, I'm delighted to be bringing a webinar on IIH, Idiopathic Intracranial Hypertension, to join the BASH webinar series. My name is Professor Alex Sinclair. I'm a neurology consultant at University Hospital Birmingham and running a research group at University of Birmingham. And I'm going to give a bit of an update on some of the newer aspects coming through in IIH. I have a number of conflicts, namely that I've done advisory boards and had speaker fees. I'm talking about migraine and headache and post-traumatic headache for Novartis, Allergan, Amgen, and Chicey. And I'm also the director and chief scientific officer with shares at a therapeutics company called Invex Therapeutics, which is progressing new drug therapies for IIH. So idiopathic intracranial hypertension, this is a condition of disordered CSF dynamics. We typically think of this condition as occurring in those that are female, and there is clearly a relationship to weight and metabolic aspects of the disease, talking about issues with cognition, and then about therapeutic advances with GLP-1 therapy and also CGRP therapy. So this was one of the largest, well, it is the largest study that's been performed with the largest number of cases of IIH, and it spanned over 10 years, and it used hospital episode statistics data from England. And we had over 23,000 cases. And you can see really clearly in the top left graph here, that incidence of IIH just going up year on year. But if you break that down into the purple, which is the women, and the turquoise, which is the men, the rising incidence is very much in women, and it's very much paralleling with the increasing obesity rates, which is the dotted line. And of course, this is a condition that very much peaks during childbearing years. The second large data study was conducted over a very similar time period, this time using general practice registry data, and it showed a very, very similar pattern with a 350% increase in incidence over 10 years. But if you look at the bottom graph, of particular interest is that the incidence of IIH really rises most markedly once BMI goes above 30, with the higher BMIs being associated with a much higher incidence. So of course, this is a condition that's diagnosed according to the Dandy criteria, which has been updated a number of times, and most recently in the IIH guidelines. And this would stipulate a patient with having papilledema, with a normal neuro exam, normal neuro brain imaging, except for indicators of raised brain pressure, normal venous sinuses, i.e. excluding a venous thrombosis, but there can be anatomical anomalies, particularly compression, normal CSF, and a higher pressure over than 25, although we do know that some normal individuals will have pressures between 25 and 30. But over the next few minutes, I want to try and present some of the data that would show you that I really think that there's a lot more than meets the eye in IIH. So this is a study that we performed a number of years ago now, which was a case control study using GP registry data, looking at the risk of cardiovascular disease in IIH patients. And we compared the IIH patients, nearly 3,000 of them, to nearly 27,000 controls that were matched for age, gender, and BMI. And what we found was that there was a doubled risk at least of cardiovascular disease, but also increased risk of ischemic heart disease, stroke, diabetes, and hypertension. And so as we look at this into the future, management of risk factors for cardiovascular disease may be increasingly important in this disease that we typically pick up in younger aged women. And it's also important to realize that this study highlights the increased risk independent of BMI. The second study is the data that looks at the hormonal aspects of IIH. And we've all hypothesized, I think, over the years about what it is about being female that may be important in IIH. And in this study, we carefully controlled for age, gender, and BMI in our control group, but also compared to women that had polycystic ovarian syndrome, another condition where there is a very similar phenotype of young women with obesity. And what we found actually when we did very detailed steroid metabolite screening, where we were able to look at numerous different steroid metabolites, what we found was that testosterone was significantly elevated in women with IIH. We looked at the cerebrospinal fluid and found that the androgens were also significantly elevated in the CSF. And when we looked at the 24-hour urine collections, we found globally increased activity of the enzyme 5-alpha reductase, which is an androgen steroid metabolizing enzyme. And we went on to look at this in our in vitro models, translating back to look at how testosterone might be involved in CSF dynamics. And in our in vivo studies, we saw that testosterone could clearly drive CSF secretion in vivo directly through the sodium potassium ATPase activity. We've looked at adipocyte distribution in IIH. And we see in these studies using DEXA scanning, which is a very accurate way of quantifying the distribution of body fat, that truncal fat is very predominant in IIH. And of course, truncal or centripetal fat is typically associated with metabolic syndrome. And we also note in these studies that the lumbar puncture opening pressure in these patients very closely correlates with the truncal adiposity. Then some work was done over the last number of years by Connor Westgate as part of his PhD, where he very carefully started to unpick what it might be that's abnormal about the adiposity in IIH and what it is about the metabolic syndrome that might be distinct. And he started by identifying that IIH patients had a unique signature of insulin resistance compared to the control population that couldn't be explained by obesity. That is, that they have increased insulin and they have increased levels of their HOMA-IR score, which is a measure of insulin resistance. So again, this is over and above what you would see in an obese patient normally. He went on to look at leptin, and he clearly identified again that, as with some of the previous literature, leptin was elevated both in the serum and in the cerebrospinal fluid of IIH patients compared to matched controls. But interestingly, it didn't correlate with intracranial pressure. We didn't see any change in the genetic transcription, in the transcriptional factors which regulate leptin, such as the leptin gene. And when we also went on to look at leptin in our in vivo models, we didn't see that it impacted CSF secretion or ICP. So we think that the leptin, the hyperleptinemia in IIH is probably a marker of the metabolic dysfunction that may not be directly driving the CSF dynamics. The study then went on to take adipose samples from patients with IIH. We took both omental and subcutaneous, and then the subcutaneous tissue was taken forward for RNA sequencing, which was an unbiased sequencing technique. And what we saw was a very distinct transcriptional profile in the lipids, in the adipocytes from IIH patients, which you can see in the first volcano plot here. And then when we looked at what those differences were, using looking at the transcriptional pathways that were differential in IIH, what we saw was that the differential pathways were very much those related to lipid biosynthesis and those associated with increased calorie intake or weight gain. So we moved forward with those adipose samples and we processed them using NMR-based metabolomics. And what we saw was there was a very different profile again of substrate utilization in the adipose tissue, such that, for example, subcut adipose tissue was able to preferentially catabolize the branched chain amino acids, and these would support the increased lipogenesis. So in summary, we were seeing really a profile of increased and differential gene transcription and preferential substrate utilization in adipose tissue that was very differential to what we would see in a control subject. So taken together, this study, which was published earlier this year, has shown that there really is this systemic metabolic dysfunction in IIH with insulin resistance and hyperleptinemia, and that actually within the fat tissue itself, within the subcutaneous tissue, we have an abnormal and differential transcriptional profile with weight that's primed for, with adipose tissue primed for weight gain, and that has a lipogenic profile. And very similar in the omental tissue, a very altered metabolite profile in the omental tissue with increased glycerol intake, increased pyruvate intake, and a reduced lactate to pyruvate ratio. So these aspects all pointing towards increased lipogenesis. So really, my first point is that blindness is really very much the tip of the iceberg in IIH. We do have the papilloma with the risk of blindness and the chronic headaches that we know well, but the data is now also pointing towards preferential truncal obesity, a hormone profile of hyperandrogenism with increased cardiometabolic risk, particularly as the patients age, and that the adipocytes actually had differential function to a control adipocyte from a similarly obese individual. The next aspect that I want to talk about is brain fog, and it's something that my patients have been telling us in clinic for over a decade, that they often, particularly when their disease is severe, have difficulty concentrating and performing the normal activities of their work because of what they describe as this brain fog. Some studies have started to look at this previously, and we took this forward into a larger cohort with prospective studies. And again, we compared against a control population. All patients had active disease at the beginning, and we followed them up for 12 months. And we used a very bespoke battery of cognitive testing and included IQ testing so that we could match our control group for IQ as well as age, gender, and BMI. And what we found, first of all, was that the executive function was markedly and significantly impaired in patients with IIH compared to control subjects. But what we noted was that the executive function and also the verbal working memory did improve over the time course of the disease with treatment over a 12-month period. Then we started to think, well, why is there impaired executive function in IIH? And in this study, we retested particularly the attention responses pre and post lumbar puncture with a withdrawal of CSF and a reduction of ICP. And we saw a significant improvement in sustained attention following reduction of ICP, indicating that ICP may well be involved in their disordered executive function. We then went on to look at a number of other aspects, and using headache diaries and looking at headache severity, we were able to see that headache severity at the time of cognitive testing impacted on their ability to perform. The longer the disease duration also affected their cognitive function. But there were a number of other comorbidities, primarily depression, which impacted their cognitive function. We also noted that their steroid profile, particularly the glucocorticoids, which are known to be involved in cognitive function in other diseases and are known to be increased in IIH, are also related to or associated with impaired cognition in IIH. And finally, the working memory, another aspect of the cognitive battery, was significantly associated with, significantly deteriorated and associated with obstructive sleep apnea markers, such as the apnea-hypopnea index. So a number of factors were contributing to cognitive dysfunction in IIH, including some of the comorbidities, obstructive sleep apnea, depression, but also the ICP itself. But one of the other things that we wanted to look at was a very practical aspect, in that we've noted in many of our patients, they have a lot of difficulty performing their Humphrey visual field testing, and they often talk about this cognitive fog and difficulty concentrating during testing. And obviously, visual field testing is our cornerstone of monitoring of visual function, so an incredibly important aspect of what we're doing in our clinical assessments. And very clearly here, we saw a significant association between executive function and their ability to perform a Humphrey visual field test, and also the metrics of performance that we would look at, such as false positives and false negatives. So in a nutshell, in those patients with active IIH, the worse their executive function, the more difficult it was for them to accurately perform a visual field assessment. So to summarize those cognitive aspects, which are just coming through for publication in brain communication, we saw impaired executive function in IIH, but that this can recover and improve over a 12-month period where patients' disease improves. We saw that it was contributed to by intracranial pressure with improvements after lumbar puncture, but also other factors such as headache severity, depression, and obstructive sleep apnea also were related to impairments of cognition. And all of these things together contributed probably to why patients seem to have difficulty performing Humphrey visual field assessments, and we saw significant associations between the performance metrics of the Humphrey visual field and their executive function. So we're starting to now think about how we can manage these comorbidities to improve this cognitive fog that our patients discuss, and be more cognizant of asking about cognitive deficits in our patients. So for the last part of the talk, I'm going to talk about treatment advances in IIH. The last Cochrane review we had was in 2015, and at that point we had the large American IIH treatment trial and some of the other smaller trials, including the Birmingham trial looking at acetazolamide. And they stated that there was insufficient evidence to recommend or reject the use of acetazolamide, and there was insufficient evidence for the use of other drugs in IIH. And currently we have no licensed bespoke targeted therapy for IIH. We started to think about new pathways and new treatments, and we started looking at the GLP-1 receptor agonists, because these drugs are, these agonists are known to modulate secretion in the renal proximal tubule and obviously alter secretion and fluid dynamics there, but they are also currently used widely across the world to treat diabetes, although they don't cause hypoglycemia, and they have anti-obesity effects. So we started to see if this could be a pathway occurring within the brain, within the choroid plexus, which is where we produce cerebrospinal fluid, and we mapped out the signaling pathway through that GLP-1 receptor, and then through cyclic AMP, protein kinase A, and directly to the sodium potassium ATPase, that dominant driver of CSF secretion. And then we moved forward from our in vivo studies from our in vitro studies to the in vivo studies. And in our rodents, we were able to use the GLP-1 receptor agonists to significantly reduce ICP by about 44%, which was a much greater extent than what we'd seen with other existing IIH drugs. And that it did it in a very sustained way, with one dose working significantly for 24 hours and with cumulative dosing over the progressive week. So James Mitchell has spent his PhD over the last few years taking this through into humans with a physiological study called IIH pressure, where he used telemetric ICP monitors and administered the GLP-1 receptor agonist exenatide and looked very quickly at how changes in brain pressure occurred, and then over a prolonged dosing of 3 months. And this was done in a blinded randomized control trial in 16 patients. And the first data is the overnight data, which I find particularly interesting because it shows here in black how ICP rises in normality overnight, particularly in these IIH patients. They often wake up with a morning headache from the ICP continually rising at night. But if patients had been dosed with exenatide, that nocturnal rise in ICP was abated. And this is our primary outcome measure. I won't go into all of the details of this study, but suffice to say that the drug worked very quickly. So acutely, within 2.5 hours, there was significant reduction in ICP, which remained at 24 hours. And then prolonged dosing over the 12-week period also significantly reduced ICP. Now, these measures are actually in millimeters of mercury with a conversion to centimeters of water. But this is about a difference of about 5.5 to 6.5 centimeters of water, so clinically meaningful and important to patients. And we're now taking this data forward into an academic trial sponsored by the University of Birmingham, which will be opening around the UK, and we'll be looking for sites in the short term due to open in the spring, testing this GLP-1 receptor agonist in a large group of patients, about 200 patients with IIH. And also the company Invex Therapeutics will be taking this forward into a large phase 3 run internationally all around the world. So finally, I want to come on to talk about headache. This is the BASH seminar, and obviously headache is something that most of us spend a lot of our time managing and thinking about. Headache in IIH is complicated and often very difficult to treat. And that is often because there is multiple phenotypes going on. There is the raised ICP, many of the headaches are migraine-like, and the evidence is mounting for that. There is medication overuse in about a third of patients, and those that get shunted have increasingly complicated headaches that could potentially be related to high pressures or overdrainage. This is a review that we've just put out recently, which talks about the complexity of the headache. And if you turn to the blue side initially, in the early part of the disease, in the acute phases of IIH, the papilledema is present, and the headaches typically come with increasing frequency of attacks, often with migraine phenotype, and elevated ICP will provoke the IIH, and often a reduction of ICP, for example, lumbar puncture, can help in the short term reduce the headaches. And the phenotype, if you take that story from the patients, often resembles an episodic migraine phenotype, migraine-like. There's very limited evidence for how to treat these patients. We've got evidence coming through from there's evidence from our previous weight loss study in the BMJ that weight loss can improve this early acute headaches. We certainly see from the American trial that the headache impact test 6 didn't improve with acetazolamide, but there's been no randomized control trials really in this area. But we would hypothesize that reducing ICP would potentially help these elevated ICP headaches. But then things can change in IIH, and as time progresses and ICP falls and begins to normalize, sometimes the headaches remain. And these are what we term persistent post-IIH headaches when the papilledema has resolved. And although we haven't got hard evidence on this, our clinical studies would make us point towards thinking of a number of risk factors for persistent headaches. And these are very similar to those with persistent post-traumatic headache. It's previous migraine, family history of migraine, medication overuse, psychological comorbidity, obesity, and obstructive sleep apnea. And this headache phenotype in these persistent post-IIH headaches is much more like chronic migraine, with a background daily headache that varies and superimposed attacks of migraine-like pain. And again, there's very limited evidence on how to treat these headaches. And I'm going to show you some of the data that we've got on Ireneumab, but generally we're using drugs off-label here, or we're using drugs on-label to treat the chronic migraine once the papilledema has settled. But we need to be very cautious when doing so, not to use drugs that increase weight or decrease mood, as these are problems typically in IIH. So we tend to head towards topiramate, candesartan, and Botox when it meets NICE criteria. But in these patients that do have the persistent post-IIH headache, we conducted an open-label trial using a CGRP monoclonal antibody, Ireneumab, which was provided to us on a free-of-charge scheme by Novartis. And we enrolled into this study 55 patients with IIH, and these were our patients that had had very long-term refractory headaches with at least 1.7 years of chronic stable headaches. Many of them had daily headaches. Many of them had medication overuse, about half of them, and many of them were on opiates. So they really were a very difficult group to treat, and they've been refractory to numerous agents, at least 3. And what we saw was a very marked reduction in the monthly headache days by -6 by 3 months, and that effect maintained over the 12 months that we followed them up. We did a sub-analysis in those that had or did not have medication overuse, and the results were exactly the same. And we did another sub-analysis in those that had had previous migraine and those that didn't. So even in those with de novo headaches at the time of IIH, which had then remained, they also had a similar reduction, similarly significant reduction in headaches. So it does start to lay the possibility that these persistent post-IIH headaches are driven by trigeminal vascular activation and release of CGRP, and that these therapies may be very useful in IIH, particularly because of their low side effect profile. But we also noticed something similar in another group of 7 patients who were on Ireneumab treatment. These again were IIH in ocular remission, but they had recurrence of papilledema. And what was very interesting is that they didn't have any recurrence of their headache at that point. So this is patients now with active IIH, active disc swelling, and here the CGRP monoclonal antibodies are still controlling the headache. So 2 important take-home messages here. One, that CGRP may well also be involved in acute IIH headache when pressure is high, but also to be aware that if you do have IIH patients that do get treated for their chronic migraine with Ireneumab, you may not see a recurrence of headache when their papilledema recurs, which could actually be very dangerous because it can be harder to therefore spot when they're having a recurrence of disease. So be alert to clues such as visual disturbance, increased weight gain, and they of course need their regular monitoring. So I've talked to you about a number of different aspects of new data that's been coming to the fore over the last 18 months or so. The rising incidence of IIH, a number of studies now pointing us towards this being more of a systemic metabolic disease. I've shown you some of our data pointing towards why patients talk about cognitive fogging, and that this is probably a multifactorial cognitive fogging with executive function particularly picked off, responding to lumbar puncture. But overall, this is clinically relevant because it's going to impair their ability to reliably perform a Humphrey visual field. And then I've talked about new directions for therapy, looking for new targeted therapies with GLP-1 receptor agonists to reduce CSF secretion and ICP. And then also thinking about more the headache aspects, whether we can start to target CGRP to combat the persistent headaches that we often see in IIH. So it just remains for me to thank very much my brilliant team at the University of Birmingham. We have a very translational group of basic labs and also clinical scientists working very closely together to try and bring through these translational studies. So thank you very much to my team. Thank you.
So thanks very much, Alex. Comprehensive talk, and we look forward to speaking to you at the end of all the talks. So I would like to invite the second speaker. Susie Mullen is a consultant ophthalmologist. We could call it neuro-ophthalmologist because she'll do all the research that is linking eyes with the brain. So it's not only IIH, but giant cell arteritis and other things that have close correlation between eyes and brain. So I think she's going to talk about the weight loss trial in IIH. So Susie is a part of the IIH team in Birmingham. As I said, and she's going to talk about that. Susie?
Thank you very much, Professor Ahmed. So I'll just get up sharing my screen. And I would say, please do ask questions in the chat as we go along, because obviously as we move through the different aspects, I know there may be some clinical questions you might would like to ask the three of us when we get to the chat. So I'm going to talk about the role of weight management. Professor Sinclair has really nicely outlined the differential issues around weight in patients with IIH. It is a very sensitive issue for patients, and I'll just touch upon that in my talk. I do have some disclosures. They mainly relate to educational talks. The thing that relates to IIH most is OCT imaging with Heidelberg, and also the spin-out company from the University of Birmingham that Professor Sinclair has already talked about. And we've been working very hard, as Professor Ahmed said, in Birmingham to really help our patients and help our colleagues with both investigation and management in this quite tricky condition. And what was really shown in the first talk is there's been an explosion of this disease. It wasn't a disease seen, you know, in the 1920s and 30s. It's really a disease that we've seen from the 1960s onwards. And we're starting to see more of our patients, and we're also growing up with our patients and learning a lot as the disease goes through the decades. And these are a number of open access publications which address a number of clinical questions. So please do download them because they can be a good aid memoir in clinic. And what was really outlined is that this disease is a disease of people that are overweight with recent weight gain. It's actually a disease of social deprivation. We've shown that through 2 studies, which have been very large within the UK population. They have very disabling headaches. A small proportion, about 7%, have significant sight-threatening disease that requires neurosurgery. A lot of our patients, maybe up to a third of our patients, have comorbid psychiatric and psychology issues, along with anxiety and depression, mental health issues. You know, the talk talked a lot about this brain fog that we've kind of ignored as doctors. There's also a fatigue element with the disease, and it's been nicely shown this idea that this is actually a metabolic disease, and it's a disease that carries a lot of emotion with our patients in clinic. And what we're really worried about is uniquely they have an increased risk of cardiovascular disease that's over and above the normal would be for patients that just have similar amounts of obesity or being overweight. So we've got quite a complex disease here that we used to think was quite simple. And it's been shown since the 70s that weight gain really precipitates the disease. And that's a real challenge. It's a challenge to talk to patients about this, particularly when they come in acutely. And this was the study that Professor Sinclair talked about, where we looked at what point in the UK did the disease take off, and it very much matches that of our international colleagues. Around about a BMI of about 30 to 32 is when you start to really see this disease take off. And so when we do see patients that have a BMI of 30, often we think, well, maybe they're atypical patients, but actually it's well within the disease remit to see patients with a BMI of 30. And the Birmingham weight loss study was talked about. It was a nice study that used a very low calorie diet of the Cambridge diet over the course of a 3-month period. And what that showed beautifully was that if you reduced your body weight, you were able to reduce your intracranial pressure acutely. This was a great start study to show us that acute weight loss could really make good effect. The problem was when the weight loss stopped, there was no real backup to help maintain that weight loss. And if we look towards the weight management literature, we will see that maintaining weight loss is one of the trickiest things for all our patients. And within about 2 years, the weight loss that's been acquired is quickly put on again. And that's a real risk for IIH, because if you go over your personal threshold that has sort of kicked you into the disease and you regain the weight, you're likely to reoccur, and that gets a second hit on the optic nerve and your papilloma. And you're going to start to accumulate damage at your optic nerve. And this is quite nicely shown by some of the teams. There's 2 teams in America that have shown that weight gain is really associated with relapses of the disease. And our group in Birmingham also put out post-lockdown in the United Kingdom. Our IIH patients put on double the national average for weight gain over lockdown. And that pushed a lot of our patients into sight-threatening disease or more active disease. So the evidence is there that rapid weight gain makes the disease occur, and weight loss reduces the disease and puts the disease into remission. And then if you regain the weight, the disease reoccurs. So you can see this sort of vicious cycle our patients get in. And for those of you on the webinar tonight that are not part of the UK NHS, the National Health Service, there's not an awful lot within the UK that can help our patients sustainably lose weight. And when we group together with many different disciplines, including neurosurgeons, neurologists, radiologists, our patients and carers, they really prioritise what methods of weight loss is going to help our patients with IIH have sustained remission of their disease. And this trial was set up many years ago, as all trials take a lot of time in planning, in obtaining funding, and then moving forward into action. And we've just recently reported this trial. There's a number of people listed on this screen. Obviously, there are many more people behind the scenes making this happen, including many people around the UK that helped contribute. And not only that, all the patients that took part. There are no disclosures relating to the trial. And the hypothesis really was that bariatric surgery would be superior to a dietary intervention, which here we've formally called a community weight management intervention, reducing intracranial pressure amongst IIH patients, and also mainly because bariatric surgery would produce sustainable weight loss in the long term. It was a 5-year multi-centre trial recruiting patients from National Health Service clinics, both neurology clinics and ophthalmology clinics. And the inclusion criteria were that was a typical IIH patient, that is a female patient in childbearing years. And we took the cutoff of a body mass index of 35. And the reason we did this is within the NHS, we have NICE, which is the National Institute of Clinical and Health Excellence. And they set the sort of bars at which patients could enter a bariatric surgery pathway and obtain surgery at the end of that pathway. And if you have no comorbidities, no other diseases like type 2 diabetes, that level's set at a BMI of 50. If you have a comorbidity such as type 2 diabetes, it would be 35. And obviously IIH is not currently listed as a comorbidity, but so we thought this was an excellent level to set it at. All the patients needed to meet the diagnostic criteria for active IIH. And within this trial, there are many exclusion criteria, as there are with trials, and that can be found within the full article. And really the methods of the trial were that patients would be randomized to a bariatric surgery pathway or the dietary arm, which in this trial was Weight Watchers. And we were very pragmatic at deciding what surgery type it would be as the patient and their surgeon would recommend, rather than sort of dictating the type of surgery. So here you see a sleeve gastrectomy, a laparoscopic band, or a Roux-en-Y gastric bypass. And the outcome measures are really important to us in terms of intracranial pressure. This was done for 12 months. There were many secondary outcomes, which included not only lumbar puncture, but all your aspects of visual function and also your headache outcomes. And the evaluations were throughout the first year and then to the second year. And we've also got a 5-year follow-up plan for our patients. And when we perform trials, it's really important to set your sample size calculation. And in our Birmingham weight loss study, where we were able to see how much of a reduction you can get in your intracranial pressure with a very low calorie diet, we saw the reduction was about 8 centimeters of CSF. And so we kind of inferred that surgery should be able to achieve an 8 centimeters of CSF, and a smaller reduction would be seen in the dietary arm. And we move forward, therefore, to detect a difference of 5 centimeters in CSF between the two arms. With all trials, you calculate your withdrawal rate. And based on all the assumptions, we needed 66 women to partake in the trial, with 33 in each arm. The statistical analysis was obviously set a priori, and that was set as an intention to treat analysis. We did have a secondary outcome, which was a per protocol analysis, which we'll talk about a little bit later as part of our planned secondary analysis. And so the results of which were, it was a really popular study. We didn't need to screen very many people to get the numbers that we needed. And as in any study, and also in, say, a bariatric surgery pathway, not everyone ends up having surgery. And that's important to note, because that's very typical within our normal NHS services. And not only that, some of our patients who are on the dietary arm opted to go for private surgery. So there was a little bit of a change within the groups, but the initial analysis was done on intention to treat. And we didn't lose many people as we went through the 2 years, which was excellent. And a lot of our patients, if they did decide against lumbar puncture, still remained, so that we could actually check their other things such as visual function and headache. And the first part of our results really informs us that the group that we had were very typical for IIH. The mean age was 32. They had a long disease duration of about a year, and the lumbar puncture mean pressure was 35. The primary outcome, which was to look at the difference between the two groups at 12 months, really showed the very significant difference of 6 centimeters of CSF between the two groups of diet and surgery. And then when we go on, we can see the large difference between the surgery arm at baseline and also 12 months. And again, the non-significant results between the dietary arm over the course of that first year. And these results had sustainability out to 12 months or to 24 months. And all our other results, so that was the intracranial pressure initially I was showing you, all the other results of weight, body mass index and excess of body weight were significantly greater in the surgery arm as compared to the weight management arm. And to really reflect this, to show you the percentage change both in body weight and ICP, you can really see the difference between the two groups. Some of our other positive secondary outcomes include quality of life outcomes, and this is really important, particularly not only for the patients, but when we talk about health economics and whether in our hospital system or NHS system, whether this is affordable for the system, which in some of the subsequent papers that you'll be able to see online shows that it really is over time. As to adverse events, there were very few adverse events, most of them related to exacerbation of IIH and exacerbation of headache. There was one patient who had a serious adverse event, which was a mesenteric stitch, which was a very short admission that didn't result in any long-term sequelae, and there were no deaths within the trial. When we think about limitations of trials, it's important to note these are usually limited by the inclusion criteria. We looked at women, so obviously relating this to patients that are either male or have a BMI of less than 35 may not be applicable, but it's important to look through to the weight management literature to show that between a BMI of 30 and 35, there are excellent metabolic and glycemic effects for those who undergo bariatric surgery. So our conclusion for the trial was that bariatric surgery was a real winner in terms of sustainable outcomes up to 24 months in terms of intracranial pressure, disease remission, and also superior quality of life outcomes. And what we want to do now is take these forward so that we can lobby the NHS to be able to make IIH a comorbidity so that our patients could access this treatment below a body mass index of 50. And as I said, there were many people involved, and you know, we would love to thank all the patients and everybody that took part in the study. Now, I have a few more minutes left, and what I wanted to highlight was some of the other data that has come out of this study. And often we're asked in our clinic, how much weight do I need to lose, doctor, to reduce my intracranial pressure? And this is one of the questions that's kind of been enduring for a long time throughout the literature, to say, well, actually, how much does somebody need to do to put their intracranial pressure into remission? I'll move straight to the results because you have heard the methodology of what we're looking at. And what we really showed with linear regression analysis was body weight really mirrors that of ICP, both at 12 months and 24 months. And the greater reductions in intracranial pressure were predicted with greater weight loss. And it was around about 24% of weight loss, which resulted in normalization of intracranial pressure. And we used the term normalization at a level of 25 centimeters of CSF, because that's where the diagnostic criteria sits for a diagnosis of raised ICP. And the important thing was there were further improvements when we went from 24 or 12 months to 24 months. And for expected values of ICP to cross at 25 within 2 years, it was generally required that the patients would have to be part of the bariatric surgery arm as opposed to the diet arm, and they would need to achieve a weight of 110 kilograms. And this is one of the models that the team was able to put together. And I think I'm going to talk you through it because it looks quite complicated to start with. But what we have is 3 notional participants with baseline weights of 150, which is the top line, 120, which is the middle line, and 90, which is the bottom line. And they're each allocated to treatment arm within 4 weight scenarios. So you lose 5 kilograms in the first year, 10 kilograms in the first year, 15 kilograms in the first year, or 20. And we look at the ICP values over just for time, the intervention, and also for weight. And what it shows is those with a higher starting weight need to lose more to meaningfully reduce their intracranial pressure. And it also showed that those patients, if they were in the dietary arm, if little or no weight was lost, that there would be an increase in the intracranial pressure would be expected. And that's denoted by the red line. And to cross the threshold of 25 centimeters of CSF through all weight scenarios, you needed to be allocated to the bariatric surgery pathway. So previous studies have suggested between 5 and 15% of body weight to put the disease into remission. This weight trial has shown us that actually for normalization of ICP, that we need 24% weight loss. Excuse me. And care should be taken, sorry, when exposing women to repeated cycles of dietary interventions that fail to achieve adequate weight loss? Thank you.
Oh, thank you, Susie. The problem of doing virtual meeting, I can't offer you a glass of water. But that's very, very good. Yeah, I hope you have a glass of water nearby. Right, we'll come back to you. We got questions coming in, and I'm making a note of it. So looks like we're gonna end up having a very, very good discussion at the end. So our third speaker is Benjamin Beckerly. He's going to talk about IIH intervention to save vision. Now, Ben has been a consultant neurologist in Oxford, Gloucestershire, but he obviously is more interested in academic work, and he couldn't find a better place to be in Birmingham, where the academics in the UK is probably, if not the first most important, but maybe the second most important, or two main centers in the UK are King's and Birmingham doing all the research. So Ben is going to talk about a new trial about how to save vision and what is the best evidence and what trials are coming up over the next few years. So Ben, it's all yours.
Thank you very much, Professor Ahmed. Can you hear me?
Yes, we can.
Right, okay. So thank you very much for inviting me to give this webinar on this exciting new trial. The title of the trial is The Intervention to Preserve Vision in IIH, Evaluation of Clinical Effectiveness and Cost Effectiveness. But for short, we're calling this the IIH Intervention Trial. And I'm giving this presentation on behalf of the Birmingham team and Professor Sinclair and Miss Susie Mullen. And these are my disclosures. Okay, so you've already learned quite a lot about IH today. And this is, of course, a disease which is characterized by raised intracranial pressure. And we know there's an association with obesity. And we know with the increase in incidence of obesity in the population that the incidence of IH is also increasing. What we also know is that this is not a benign condition, and up to 2% of patients can go blind from this condition if untreated. Now, the vast majority of patients with IH are managed conservatively with weight loss and medication, but when they present acutely, then they often need some form of surgical intervention to prevent visual loss, and that's what I'm going to talk about today. And this is a very important topic. This is something that we talk to our patient group, IH UK, about in the past, and it's one of their top priorities to establish what is the best surgical procedure to treat patients who acutely present with raised intracranial pressure and sight-threatening IH. And we also talk to neurosurgeons, neurologists, ophthalmologists, interventional neuroradiologists, and there's a degree of clinical equipoise between the different procedures that we use. And at present, we use obviously Csf Shunting, that's the main procedure. In the past, people have used optic nerve fenestration. And more recently, people have been looking at using intracranial stents to try and reduce ICP. But there's never been a trial comparing CSF shunting and dural venous sinus stenting, and that's what we plan to do over the next 6 years. So just a little bit of background. As you know, cerebrospinal fluid is produced in the choroid plexus and is drained in the arachnoid villi, and then into the venous system, and then into the jugular, and back into the venous system. And it's important to understand the anatomy here, because this is going to help us understand why we do these different interventions. And of course, raised intracranial pressure causes pressure on the back of the eye, which results in papilledema. And this is what the main problem in IH is, because this causes the visual deterioration. And the way that we look at papilledema is obviously using a fundoscope, but during COVID, that's been more difficult, especially with masks and face guards on. So, optic coherence tomography, or OCT, has come to the rescue, and this is a way of looking at the back of the eye in cross section, and it's now the preferred method of monitoring patients with IIH. And by using specialized software, we can look at the different nerve layers in detail, and we can monitor papilledema. And importantly, we can differentiate papilledema from patients who have pseudopapilledema caused by optic disc drusen. And this is much more difficult and almost impossible when using a normal ophthalmoscope. And in clinic, I work closely with Miss Mullen and other neuro-ophthalmologists, and essentially we can track papilledema using OCT, and this gives us an indirect guide to what's going on in the head and what's happening with the pressure, and that helps us guide treatment. And of course, papilledema causes problems with vision, and we also monitor visual fields using the Humphrey visual field system. And you can see here on the figure at the bottom left that essentially the more dark patches you see on the visual field, that's the worse the outcome. Okay, so in terms of the gold standard at present, we use CSF shunting, and the shunt is obviously a small tube which goes into the ventricular system. Often there's a valve, and sometimes there's an intracranial pressure monitor attached, and then this is drained into the peritoneal cavity, and this is called a ventricular peritoneal shunt. You can also have a lumbar peritoneal shunt, which drains CSF from the lumbar region, but these are less favoured as there tends to be a higher complication rate. So with the shunt, obviously the CSF is drained, the intracranial pressure is rapidly lowered, and this preserves vision. And we know that this works. This is a series done here, and you can see that time is along the bottom axis, and we have different stages of papilledema along the top. So the patient presented with very severe papilledema. The shunt was put in, and then quite rapidly the papilledema resolved. And we also followed up this patient with OCT, and you can see that the different the retinal nerve fiber layer and the optic nerve head essentially became less thick over time, and with this the papilledema went down. So we know that CSF shunts work. Now, going back to our anatomy and looking at the drainage system in more detail, you can see that the CSF is essentially drained into the sinuses, and we know that a high proportion of patients with IH, up to 95%, when they have imaging, they are found to have so-called sinus stenoses within the system. And you can see this here on the MRI or MRV, and this is part of the normal workup for patients with IH. And it's thought that having these stenoses causes back pressure on the system, and therefore you have a state of venous hypertension, and this results in reduced CSF absorption, which then results in increased ICP, and we go round and round in circles, and this system is maintained. And the theory is that if we put a stent in and open up these sinuses, then we can increase CSF drainage and therefore lower ICP, and we can save vision. Okay, so no one's ever done a trial looking at CSF shunting versus stenting. We know that CSF shunting obviously reduces ICP. We know that it preserves vision. And we also know that stenting reduces ICP, but we don't know about the long-term consequences of doing stenting and whether or not it can help reduce visual deterioration. In terms of complications, it's much higher according to the literature in the case of shunting, and up to 70% of shunts either fail or need revising. And there's a tendency for them to block become dislocated or sometimes become infected. And one of the other disadvantages with shunts, particularly VP shunts, is that the patient can't drive for 6 months after the shunt has been placed. Now, in the case of the stents, we know that these can become blocked, and we know that sometimes when you put a stent in, the adjacent part of the sinus then becomes stenosed. So stents aren't completely complication-free, but they have significantly less complications than the shunting. The one thing with stents is also that patients are required to be on anticoagulation for 6 months, and that may, of course, lead to some problems. So there's an excellent review on stents, which I've highlighted here, and this is open access. That's definitely worth a look. But the key thing here is no one's ever looked at stenting versus shunting. There's clinical equipoise, and we need to find an answer. Okay, so that brings me round to talk about the trial in more detail, the IH intervention trial. So this is a multi-center, open, randomized controlled trial with an integrated health economic evaluation looking at DVSS versus CSF shunting. And this trial will last for the next 6 years. It kicks off in April, and we plan to recruit 69 patients in each treatment arm, and it's going to be done across 17 or 18 different neuroscience centres across the UK. The numbers are slowly expanding, and we approach people who are interested in IH, and we're confident that we're going to be able to recruit everyone over the next couple of years. So the main clinical objectives for this trial are to compare stenting versus CSF shunting in terms of the clinical effectiveness in preventing rapidly deteriorating vision, but also looking at the economic side of things. Which of these procedures is more economical in the longer term? And this trial will occur at neuroscience centres, and patients will be recruited from neurosurgical, neurology, ophthalmology departments, and we may even recruit people from the emergency room. And patients will be randomised 1-to-1. And the target population are patients, women of childbearing age with an established diagnosis of IH, and they must, of course, have evidence of papilledema and rapidly progressive visual loss. And importantly, they must be suitable for both CSF shunting and stenting. And the main exclusion criteria are patients that have had previous surgical intervention and patients that have got ocular disease, which would make it difficult for us to assess in the setting of the clinical trial. So in terms of the outcome measures, the primary outcome measure is perimetric mean deviation. And this is something that's derived from doing the Humphrey visual fields. And that's the best way of following visual function in patients with IH. The key secondary outcome measure is that of major complications, and we're using the Clavian-Dindo grading system to look at this, and this is how we're going to determine what proportion of people get complications following the different interventions. We're also looking at a number of secondary outcome measures, including visual function. So we're looking at different OCT parameters, degrees of papilledema. We're looking at lots of different procedural details in terms of the different interventions, particularly looking at minor complication rate, how long patients are in hospital for, whether or not they represent, number of revisions, etc. We're looking at headache in detail in terms of severity, frequency, and the use of acute analgesics. And we're also using various validated questionnaires to look at quality of life. And over the longer term, we're also using NHS digital outcome data, which is a way of essentially monitoring patients without having to see them face to face. Now, in terms of the schedule of events, you can see that most of the schedule of events for this trial are clumped towards the first quarter or third of the 1 year follow-up period, and that's because that's when we expect the papilledema to resolve most quickly. And this is a Gantt chart just indicating what we're doing over the next 6 years. May 2027 seems a long way away, but that's when we'll finally be publishing our data. And the plan will be to kick off in April next year, recruit over the course of 30 months, and then follow our patients for a further 12 months. So in summary, this is a very exciting trial. By the end of it, hopefully we'll know which of these two interventions is the most clinically and cost-effective in treating patients with rapidly progressive visual loss in IH. And hopefully I'll be invited back to BASH to present the results in 2027. There's lots of people involved with this trial, and I'd like to thank Professor Alex Sinclair for inviting me up to Birmingham to join the team. And I'd like to thank all of the other investigators, and particularly Miss Susie Mullen, who's helped put this trial together. Thank you very much. And if you would like to, tweet me or ask any more questions, by all means, here are my contact details. Thank you very much.
Oh, thank you very much, Ben. That was really comprehensive and good summary of what you intend to do over the next few years. So, Alex, welcome to the live show. I hope you're enjoying your break.
Yes, thank you, Fayez. Sorry I'm late in joining, but yes, I was worried about the Wi-Fi in the Lake District, but it's wonderful to see how many participants you have online tonight. So that's fantastic.
Well, thanks for joining. So we got lots of questions, and if panelists are happy, I would direct the questions to the relevant people, and if other people like to answer, do please chip in. So some very interesting questions. Alex, we've seen lots of people, lots of women who are massively overweight, BMI of 35, 40, 45. They don't all have IIH. Why is that?
Why is that? That's a great question, and it's something that comes up time and time again. You know, I think probably we will start to unpick more and more of the pathogenesis of IIH, but we're still not completely clear about answering that question. We know from our research that there is a distinct hormonal profile, and I saw in the question box the questions about PCOS as well. And you'll see from my slides that we've picked up a hormone profile in IIH, which is very distinct, and it's there in the blood, the brain fluid, and in the urine, and it's all pointing to an abnormal androgen pathway being exaggerated. So we get increased production of testosterone through with increased 5-alpha reductase to get rid of it. And there's a number of enzymes which may be involved in generating the increased testosterone, such as AKR1C3. But we see different profiles in simple obesity, and we see different profiles in polycystic ovarian syndrome. But why people develop that particular profile of abnormal hormones is not yet apparent, just like we don't really know completely the cause of why that particular profile is prevalent in PCOS. So we have a lot of questions still to answer, but I think we have made good progress over the last decade in starting to be much more accurate in highlighting which the abnormal hormonal pathways are. And yes, the next question is to go back a step and say, well, why are they abnormal? What's going on? And some of the work we've been doing has been looking at where the hormones are being generated. So obviously androgens could be generated in the gonads, they could be generated in fat, they could be generated in the skin, but our research is pointing much more towards adipocyte generation. And I presented some of that work as well, showing the abnormal adipokines and the abnormal metabolism that goes on in the adipocytes of patients with IIH. So why it happens, I haven't completely answered with the team yet, but we're starting to unravel and unpick an abnormal hormone profile that seems to be driven from abnormal metabolism within the fat tissue.
And a question fairly relevant to that, what prevents men not having IIH?
Yeah, so I think sometimes we start, particularly as neurologists or ophthalmologists, with a very sort of black and white thoughts on what hormones do in men and in women. With typically we think about testosterone being a male hormone, but actually it's a hormone that's present in women in normality as well. It's just in much lower levels than it is in a man. And I think we have to understand the concept that hormones do different jobs in men and women. So they also have different implications if they're too high or too low. So for example, cardiovascular disease is much higher in men that have low levels of testosterone, and cardiovascular disease is much more prevalent in women if they have too high levels of testosterone. So we call this sexual dimorphic actions of androgens or hormones. They have different roles and different jobs. So in men, what we actually see is that it tends to be men that get dipping or slightly lower levels of testosterone that have more of a tendency to develop raised brain pressure. And we see that in the setting of hypopituitarism, or we see it in the setting of finasteride therapy, which is used as an androgen blocker. So it's certainly not high testosterone in men driving this condition. If anything, they suffer more if their testosterone levels become low. Whereas in women, it's increased testosterone levels. But what you have to realize is that you're still not elevating the testosterone levels in a woman to the level that they are in a man. They're just elevated for a woman, but not into the male range.
Thank you very much, Alex. So Ben, just coming to you, and I come across quite a bit of this situation, and I know what I would do, but I think people would like to know what's the consensus here. You do a scan of somebody with headache, with no suspicion of IIH, and the radiologist comments that they've got tortuosity of the optic nerve, they have got features suggest empty cella, all suggestive of IIH. Would you do a lumbar puncture?
Well, that's an excellent question, Professor Ahmed. I mean, the first thing, of course, to do is to look in the back of their eyes to make sure they haven't got papilledema. And if you can't do that, or you're having problems working out whether or not they've got very subtle papilledema, or you're worried about, they could have pseudopapilledema, then you need to find a friendly ophthalmologist and arrange an OCT, and then that will be able to essentially help you diagnose whether or not they have papilledema. Now, if they have papilledema, then you've already sort of met two of the three key clinical criteria for diagnosing IH. And the next step would, of course, be to do a lumbar puncture to see if the pressure is above 25. If it's around that level, then there's a good chance they have IH. But don't forget, it's a snapshot in time. So if the level is slightly lower, then they still could have IH. Now, if they don't have papilledema, then they could have a condition which we call IIH without papilledema, or IH-WAP. And you could still proceed to do a lumbar puncture if you think they have, good radiological evidence of raised intracranial pressure. Looking at the new diagnostic criteria back from 2013, you are meant to have evidence of an lateral rectus palsy if you don't have any other signs. But I think if you have an empty cella, the back of the eyes, back of the globes look flat, there's a degree of optic nerve tortuosity, then it would be worth doing the lumbar puncture. And of course, if you see all those things on the MRI scan, you should proceed to do an MRV to make sure that they haven't got a subtle sinus thrombosis or sinus stenosis, because 95% of patients with IH will have evidence of unilateral or bilateral sinus stenosis, but unfortunately a good proportion of patients who don't have IH will also have this as well. I hope that's answered your question.
Yeah, let me put it in a slightly different way.
Okay.
Somebody comes and has a single seizure, no headache, right, nothing. You just did a scan, and the scan says, does the patient have IIH? You look at the fundi, you're quite confident. I mean, most of the neurologists are confident that there is no papilledema. I think it's only when there is a little bit of a doubt. But if there is papilledema, would you then do a lumbar puncture?
No, I personally wouldn't do that, because the thing is, the number of scans that come back with empty cella sign, I mean, I haven't audited this, but it's a high proportion. It's something it's in my experience is overcalled. So and we know that IH doesn't cause seizures. So unless they've got high pressure headaches or they've got chronic daily headache, then I wouldn't proceed to lumbar puncture unless you think they've got, you know, some kind of meningeal process going on, or, you know, there's a background of history with possible meningeal carcinomatosis, or with some kind of infective process going on. I wouldn't do lumbar puncture.
Well, that's what I wanted to hear, because I would just ignore it if there is no clinical.
Yeah, exactly.
Yeah.
Yeah.
Okay. Susie, there was a very good question about how sensitive is OCT in ruling out papilledema, because somebody asked the question that OCT was negative and the disc margins were a bit blurred, and they were given a sort of conclusion of grade 1 papilledema. Can you put some light on it?
Yeah, I can. So the OCT is very much like MRI imaging. It needs to be interpreted by people that know what they're looking at. So you don't get a readout of abnormal, normal. On the OCT platforms, there are various guides, and those are really set up for glaucoma. They're not set up for papilledema. And we know there's a large spectrum of how we're all built. So the nerves can be slightly elevated and be either slightly tilted or have other features that are actually normal for the person. So it's taking everything within the clinical context. And if I feel that I'm looking at somebody both clinically and with the OCT, and I'm concerned that they have very mild signs of papilledema, often what I'll do is I'll repeat that examination, say in 6 weeks or in 3 months, depending on how they are, to actually see if there's any change. Because for some of us, actually, it's quite difficult looking at the optic nerves, even when we have a dilated slit lamp examination. So it's about being pragmatic. I mean, we love OCT imaging. It's really helping us, not really with diagnosis as much, but really, as Ben highlighted in his talk, excluding pseudopapilledema, but also monitoring of our patients long-term. Particularly, there was a question about optic atrophy. Absolutely, if they've got optic atrophy, continue your OCT imaging, because if you see an inflection, there might be a block shunt. And one of our trainees published a couple of cases we had to highlight that. So very useful in the right hands. If you are thinking about doing OCT imaging, which a lot of our high street opticians do, don't just send us one picture, send us the whole file so we can look through the different parameters. In Birmingham, we do a circle scan, we do a disc volume, and we do a macular volume, and that would be our sequence for IIH. There's little add-ons for things either side.
Thank you. So one more question similar to that. You've got papilledema, you've diagnosed IAH, you put patients on treatment, say whatever, acetazolamide, topiramate, bendrafluoride, whatever. How long does it take for the papilledema to disappear, and how often or how frequent would you follow them up?
So those are two really good questions that I get asked an awful lot, and our team get asked. How soon does the papilledema disappear? Well, it very much depends on what dose of medication the patient's on, or whether they've had shunt surgery. But I can tell you in our experience, our shunt surgery patients, literally within 4 weeks to 8 weeks, will be normalizing back down to a normal level of their papilledema. So a rapid reduction in ICP, you will see a rapid reduction in the papilledema. Some of our patients, we don't put all of our patients on acetazolamide, but our patients that do go on it, we put it on at appropriate doses, obviously if they're tolerating side effects. So we're talking about 2 grams, 3 grams, up to 4 grams, such as the IIH treatment trial, and that's in a divided dose. 40% of our patients don't tolerate that, but that or a very low calorie diet, as was shown in the Birmingham weight loss study with Alex's original PhD study, showed that you can get very rapid reduction in your papilledema if you have rapid reduction in ICP or rapid reduction in weight. How we follow patients up is mainly based in ophthalmology and what their disc looks like and what their visual field looks like. And the IIH guidelines, both the UK ABN ones, where we had real international buy-in, as well as the European guidelines, both show a nice sort of algorithm of what other neurologists and ophthalmologists do. So there's a nice table, I think, in the ABN guidelines that show that.
Okay, thank you very much. Alex, two very interesting questions. We've seen with the COVID pandemic that everything is going virtual. Somebody asked a very similar question. Do you think in future there will be something available who would measure the ICP or intracranial pressure without doing a lumbar puncture?
Yes, thanks for the question, Fayaz. So non-invasive measures of intracranial pressure, I think, are somewhat of the holy grail over the last, 70 or 80 years that we've all been talking about IIH. I think we're all aware of the difficulties sometimes of doing lumbar punctures in this patient group. And indeed, we've published on the traumatic experience that a lot of patients go through when they have to have a number of lumbar punctures. So the patient input is that they don't like the LPs much of the time either. But in terms of very accurate measures non-invasively, there have been a number of things postulated. We published just in the, I think it's about 18 months ago now in JAMA Ophthalmology, the sort of first ability to quantify changes in intracranial pressure non-invasively using OCT imaging again. It was a different parameter on the OCT. We used the optic nerve head central thickness and showed very high degrees of correlation with intracranial pressure. We were then able to take that forward to a larger group of patients and again recapitulate those findings and build models to then predict changes in ICP from changes in optic nerve head central thickness, such that if you look at, for example, a 50 micron change in the optic nerve head central thickness, this will be equivalent to a particular change in the lumbar puncture opening pressure at a particular time point. So we are progressing to doing that, but of course you can't do OCT virtually in somebody's home yet, so it's not completely COVID safe. What I would say about some of the other measures that have been postulated, such as optic nerve sheath measured on ultrasound or tympanic membrane movement, or when they use globe tympanography, a lot of these methods are able to tell you if the pressure is high or low, but they aren't able to give you a graded readout of just how high or just how low the pressure is. So I think we still have a way to go, but we are taking forward our use of OCT to predict changes in ICP. And actually we are interested in potentially using that in some of our astronaut populations on the International Space Station, as well as a non-invasive way of trying to evaluate intracranial pressure.
Very good, very good. Somebody asked the question that premenstrually, I start to develop features of IIH. Is there any evidence that some hormonal exacerbation or estrogen withdrawal or estrogen drop may be related to IIH, intracranial pressure?
Yeah, so I don't think there has ever been any study which has sort of progressively measured changes in ICP over a menstrual cycle. I guess I would come back to the question and I would ask, what do you mean I start to develop my symptoms of IIH? Do they mean their papilledema is coming back premenstrually? Probably not. I suspect they're meaning that their headaches are exacerbating premenstrually. And then I think that that would probably be quite logical. And as headache doctors, we very often see headache exacerbations premenstrually with falling progesterone levels. And so I think that we'd need to unpick that question a little bit more to understand it, but certainly we haven't got any relationship between changing or fluctuating hormone levels and fluctuating ICP at this stage.
Okay, Ben, that's just me being a devil's advocate. You're comparing stenting versus the shunting. Why not standard treatment versus stenting and standard treatment versus shunting? Why they are compared to each other?
Well, the standard treatment at the moment is of course CSF shunting. So there's only a few centres in the UK which do the stenting. So we're comparing the new kid on the block, which is the stenting, with what's already established as an effective way of lowering ICP rapidly.
Right. I mean, 5% of the people have bilateral venous stenosis, and about 37% have unilateral. And
yeah, something like that.
So, I mean, people say that this is a result of the IIH rather than the cause of the IIH.
Well, it is a chicken and egg scenario. I mean, one of the things that, in terms of patients coming into this trial, they have to be suitable for both CSF shunting and stenting. So as part of their workup, they will have venography, either an MRV or a CTV, to make sure that they have a stenosis that can be stented. And then when they actually have when they actually go and see the interventional neuroradiologist, they'll actually measure the pressure gradient across the stenosis to see whether or not it's a relevant stenosis. And if the pressure gradient is above about 8 millimeters of mercury, then there's a good chance that it's relevant and therefore suitable for stenting. And once they put the stent in, they'll relook at the pressures to make sure that it's come down. And in that way, you can show that the stent is effectively reduced venous hypertension, and therefore there's a good chance that, you know, the knock-on effect of that will be that there'll be increased CSF reabsorption, and the pressure will eventually go down. So the get out clause is that they're actually going to measure the pressures before and after they put the stent in, and that will help determine whether or not A, it's relevant, and B, whether or not the stents worked, at least in the short term.
Yeah, no. What my question was, how you choose to randomize between shunting and stenting? Does it depends on whether they have got a stenosis or
no? Everyone will have a stenosis that goes into this trial, and then they're just randomized, toss of a coin, 1-to-1.
That's good. That's good. Thanks very much. So, Susie, just coming back to you, bariatric surgery. My experience is that the surgeons usually say, "Oh, it doesn't fulfill the criteria." Can you just bullet point when the surgeons would be able to take them, so that we can actually refer the most appropriate patient to them?
Yeah, so I think in the setting of the National Health Service, that's a really sort of helpful point to say to anybody listening tonight. So the UK currently, bariatric surgery would be agreed upon with a body mass index of greater than 50 if you have no other comorbidity. And comorbidity, I mean things like type 2 diabetes. Obviously, if you have something like type 2 diabetes, if you have a BMI above 35, then you would be eligible for bariatric surgery. What people need to do is talk to their local services and see what the actual pathway will accept. We have very good relationships with a number of different services in the Birmingham region, and they will take our patients below a BMI of 50, because the pathway has lots of excellent things within it, the multidisciplinary team that can help people that may not need surgery at the end of, say, the year assessment. And locally, things are very different up and down the UK. So it's very important to really engage with the services and see what the surgeons and also the team, because the surgeon is only one part of this team. There are endocrine experts, dietitians, psychologists within it. And a lot of our patients, that's how we talk to them about the pathway, that the majority of people don't end up with surgery, that the help within that service is enough for them to achieve sustained weight management. The other thing to say is bariatric surgery isn't for everyone. For many different reasons. And we're very lucky to see some of these GLP-1 inhibitors coming in for patients with weight management, for sustained weight management. There's been some fantastic trials that we've seen come through the Lancet very, very recently, and for these drugs to be licensed within the NHS, within a weight management service.
Can I add something to the end of that? Sorry, Fias, for interrupting. The other problem with trying to get access for the IIH patients, as Susie was saying, is this sort of differences of the rules, if you like, the CCG rules around the UK. But one of the things that may help to harmonise that is our publication and then feeding into the NICE guidelines for bariatric surgery. So periodically, the NICE bariatric surgery guidelines come up for review about which comorbidities they will accept have sufficient evidence for. So we will be working to try and see if we can actually get the IIH patients included in that cohort now on the back of the type 1 evidence. But presently and in the past, it has actually been very difficult because of the lack of evidence and lack of NICE guidance in this area.
Yeah, because I must say, I think this is very gray area, and some people put emphasis on one comorbidity than the other. So it's not black and white. And I've had quite a few occasions that the bariatric surgery was turned down because of, some surgeons prefer to have one than the other.
Very true. And also, I think post-COVID now, there is huge difficulties, as we all see, with the backlogs coming through the hospitals. So I think that the bariatric services are very, very pushed at the moment. And what effect that usually has is that they prioritize those with an even higher BMI. So individual regions of the country are really probably got different thresholds for what BMI cutoff they're using, and that's exacerbated with COVID. So I think we have to see how things progress over the next time period, over the next few years, but hopefully we can get more of a structured consensus on that with NICE guidance.
Okay, I'm going to throw one question, basically starting with what I do, and then there is a lot of controversy and a lot of pressures among the general physicians and others. You can take the answer, or you can give the answers in turn while I'll go through some of the other questions that came on later. And patient education also comes into play here. Pressure for doing lumbar puncture. I've seen physicians, particularly in acute medical unit, known to have IIH, presenting with headache, lumbar puncture. Patient pushing, can I have a lumbar puncture? My symptoms get better, can I have a lumbar puncture? I've only got headache. Ophthalmologists have said visual fields are absolutely fine, but the patient and the physicians go on for the lumbar puncture. Can you give a unanimous guidance, three of you, while I'll have a look at the other questions?
Absolutely, Fires. And perhaps I'll just kick off and then refer around the virtual room. But it's quite clear what the international consensus and what the guidelines say on this. We do not advocate any longer serial lumbar punctures to manage IIH. And that is for a number of reasons. There is a lack of evidence, but there is also evidence of harm. So lumbar punctures to manage headaches has been shown to be poorly effective in the long term. There is often a very small significant improvement over the first couple of days, but there's still a very high chance of low pressure headaches and problems post lumbar puncture. And the very moderate improvements that they get in headache will be negated after the first week. So it's a very short-term strategy. The other problem is, as I've mentioned, is that lumbar punctures can be very difficult for patients. Although some of them like and ask for a lumbar puncture, there is also a body of patients that find them very painful, very traumatizing, and a very difficult ordeal to go through. And then I guess the other thing that I would add is that when a patient comes into casualty and they have a diagnosis of IIH, is it active IIH? Do they actually have papilledema at that point? Because very, very many patients coming into casualty who have had IIH may actually find that their papilledema has now settled, and they have IIH in ocular remission. There's no longer papilledema, and we have ongoing headache issues, and we call that persistent post-IIH headaches. And in that case, what the need there is to really phenotype the headache and assess what's going on, because very many of them will actually be having migraine exacerbations and will be better treated in the long term if the headache is managed directly, not given a sort of short-term high-risk procedure repeatedly. So I'll send that over to Susie now.
Yeah, I mean, as Professor Sinclair has really outlined, lumbar punctures are very difficult, and a lot of our patients do say, whether we're in the headache clinic or the IIH clinic, that the LP really worked. Doctor, please, can I have another? And as we know from physiology, the CSF reproduces incredibly quickly, so their pressure's really going to be back to normal within a number of hours. And also the effects of low pressure. So you might have a lumbar puncture that works well and gives you a bit of relief, but we've certainly had cases with profound low pressure headache, which is really challenging to manage, particularly in this age group who could be working or young moms, really, really challenging. So we really see the LP as a diagnostic thing. The only situation where we sometimes perform repeated lumbar punctures would be in a young patient who has active, really florid papilloma in, say, the first trimester of pregnancy, where we're really trying to manage the patient through the pregnancy and try and avoid a shunt. But our neurosurgical colleagues have really come to the fore in helping us not only with lumbar drains, but other advice. So isolated LPs for us is something we just we're not continuing to do.
Ben?
Yes, thank you, Professor Ahmed. Yes, I would echo exactly what Ms. Mullen and Professor Sinclair have said. Of course, it is doing serial lumbar punctures is probably more common than we think, especially in DGHs, and it's something that over time I've tried to persuade people not to do. I think the key thing is if someone comes in with known IH, get the obviously if we think the pressure's up, talk to a friendly ophthalmologist, because that's really going to guide us in terms of what we do. If there's evidence of worsening OCT papilledema, then that indicates that the pressure's up. If there's no papilledema at all, then we know that the pressure must be normal or low high. But I certainly wouldn't rush in to do a lumbar puncture, because so many times these patients end up with low pressure headaches, and then they're in bed for a week in hospital, and then they get other problems, and it's just something that we see all the time. So again, I wouldn't recommend them. Sometimes I admit that sometimes I have recommended it in pregnancy, and that's just because at the time there hasn't been any other options. But it's something that I wouldn't normally recommend in other situations.
Okay, one question came from David Watson. There is no particular characteristic of IIH headache. So firstly, is that the IIH always accompanies migraine? Because the features of headaches for all IIH are migrainous headaches. Unless they have medication overuse, then we blame them. Secondly, is migrainous aura, how can you differentiate that with the visual obscuration that people with IIH would have?
Okay, that's a really good question, Fayez. I'm going to start with the beginning part of that question and then put the visual aura stroke obscurations over to Miss Mullen, because that's a very common thing we see in clinic. So the first part of the question, you're wondering, just remind me the first point of the question.
There is no specific type of headache for IIH.
Yeah. So I think the increasing awareness is that most headaches, migraine including, and also other secondary headaches, have a final common pathway, likely through trigeminal activation. And most of these headaches with the secondary headaches will have migrainous phenotype. So whether you look at post-traumatic headache, persistent post-IIH headache, or migraine headache, they all do have very similar features. Some of them will become chronic migraine, these chronic post-traumatic headaches, which have migrainous features, or the migraine-like post-IIH headaches, and they all have this sort of background headache with migrainous spikes superimposed, where they have these migraine-like attacks. So I don't think we are saying that the headaches are separate. I think what we were probably finding now is that they probably have a final common pathway, which is quite similar between a lot of different headaches. We are showing elevated CGRP in IIH headaches. We obviously know it's elevated in migrainous headaches. It's been now shown by some of the Copenhagen team that you get a CGRP signal in post-traumatic headaches. So I think that we are moving away from didactically sort of separating headaches based on the cause, but more thinking about them in terms of a final common pathway of trigeminal vascular activation, and the manifestation is therefore of migraine-like headaches. So I don't think it is possible really to tell IIH headaches apart from migraine-like headaches, and many patients will have both. But we do also have patients that have never had migraine headaches at all in their life, will get a diagnosis of IIH, and then will develop migraine-like headaches. So clearly the raised pressure can provoke or induce or lower the threshold for their trigeminal vascular activation, and they can manifest with IIH headaches which are migraine-like. So I think we are seeing a spectrum, but I don't think that there is a specific IIH phenotype of headache, no.
Thank you. Susie?
And talking about visual migraine, aura, and also transient visual obscurations, they're very, very different characters. I was going to say very different beasts, but very different characteristics. So what we think of transient visual obscurations in raised intracranial pressure from any cause at all is that you have a graying out and a blacking out of vision that can last for maybe very transient seconds, maybe up to minutes. And characteristically, there's some patients that are very susceptible to these. They might get them when they bend down. It's not necessarily in both eyes. It's typically in one eye, usually the eye with the worst papilloma. Often papilloma is very asymmetrical. And so often it'll be either the right eye or the left eye. And once these start to come when patients are either sedentary, sitting down watching the television or something like that, or coming in increasing frequency, I really start to worry about those patients. Because those patients, their nerve is really under critical stress and they may be heading towards a surgical procedure. Obviously, many people on the call, because it's a BASH webinar, will understand those characteristics of a migrainous visual aura, where you get sort of fortification spectra, lights, photopsias. You maybe have a scotoma. It's very, very different. If you have a scotoma in IIH, of which a few of our patients do, it is usually permanent, and it's usually something that is very, very small, and it doesn't change with time, and that's obviously a really bad sign in IIH. So the two are very different in characteristics.
I mean, do you think that there are positive and negative? I mean, you get more positives, high positive features with the visual obscurations or with the migraine aura?
Yeah, so in terms of how you define positive and negative scotoma, it really is graying out and blacking out of vision for your transient visual obscurations. So they go down to absolutely nothing within the eye. And as you'll know from your migraine auras, there can be maybe a central scotoma of which you're unable to see from. They're just very different in length, characteristics, where they are within your visual field and how they change over time. So obviously your visual aura will change over time, whereas transient visual obscurations literally do kind of snap back.
Yeah. You were going to say something, Alex?
Yeah, I was just going to add something to that. I mean, it is a very common question, and Ms. Mullen's gone through those characteristic features. I guess the only other thing I would add is that also the timing of all of these. So obviously visual aura can occur at any time in a headache, but it's most common typically just before an onset of a severe headache. So you can also look at the timing. But I was also going to add the other differential diagnosis that we often have to pick apart for visual phenomena in our IH clinic. And that can also be bilateral, usually bilateral blurring or graying of the vision. And that's actually when patients have a postural hypotensive episode, a lightheaded episode, like a vasovagal syncope. So it is also worth asking, at the time, were you standing up? And were you also feeling lightheaded, and did you black out or pass out? Because obviously, as headache doctors, we see many, many people that have sort of postural hypotension and vasovagal features when they have severe pain.
Have any of you come across an IIH patient with visual snow?
So visual snow, I see a lot in my neuroophthalmology clinics. It is not typically a feature of idiopathic intracranial hypertension. I think I'd feel very sorry for the patient who also has IIH, who also has symptoms of visual snow. Both can be very intrusive.
I've certainly seen one or two patients who have got symptoms very suggestive of visual snow, but they are already known to have IIH. Okay, just one last question to Ben, and then I think we're going to come to a close. We haven't heard in the last couple of hours about optic nerve fenestrations. Is that got any role in it?
Well, historically, people did do optic nerve fenestration. So they essentially expose the optic nerve, and then Miss Mullen will be able to tell you the details more competently than me. But essentially, you make a little slit in the optic nerve, and then the CSF leaks out, and of course that reduces the ICP. Now, as far as I know, people used to have it just done one side at a time, and there is a risk. Well, what happens is this slit obviously fibroses over over a period of time, and then the window, as it were, becomes closed and it stops working. But it's something that I mean, I can't remember the last patient that I had that had an optic nerve fenestration, and I think it's done probably by a few people at a few centres in the UK, non-routinely. But I think I'll now pass you over to Miss Mullen to tell you, because she's probably done some in the past herself.
A very long time ago, Ben. There are very few centres in the UK that do this. So Professor Sinclair and I have looked over a number of years at the hospital episode statistic data, and there are very few cases that are performed in the UK. And that's actually mirrored in the United States. So the United States have put out their surgery data, and for every 10 shunts that go in for idiopathic intracranial hypertension, there's one optic nerve sheath fenestration. And when I talk to my senior colleagues about it, many of whom, did this many years ago, the problem is that there can be high side effects directly to the optic nerve. And that's really challenging when you're trying to save the sight, losing any amount of sight because of the surgery type. The newer surgical techniques look better in side effect profile, but we don't have many surgeons around the UK that we could call on in the next 24 hours to really treat that sight-threatening papilloma. And that's really why our neurosurgery colleagues and our interventional neuroradiology colleagues, they're set up for these emergencies, and why optic nerve sheath fenestration has really fallen out of favour.
Yeah, I mean, I agree with you. It's been a long time since I've asked anybody to do optic nerve fenestration. So just wanted to catch up for the audience that there is no role, unless it's an acutely threatening vision. Would you then say that there would be some role for a temporary, window, making a temporary window?
Not unless you've got demonstrated effect of losing vision, because it's a tiny surgery for the patient. It's a massive surgery for the eye and the optic nerve. So in terms of benefit versus risk, it's not something that I would want to be done to me. So
you would rather prefer a lumbar drain rather than?
Well, I think if I'd sight-threatening surgery, it would be, as Ben says, once the trial comes out, we'll know whether it's a shunt or whether it's stenting. Yeah.
It's such an evidence-free zone, isn't it, at the moment, because there's been no randomized controlled trials of these types of surgical techniques for fulminant IIH. So these techniques should only be performed when there is sight loss threatened. So we call that fulminant IIH. And the evidence for optic nerve sheath fenestration is even less really than there is for shunting. So really, I think it would be a difficult call to sort of put the data and the evidence at this stage behind why you've chosen a procedure, particularly in the UK when the skill set's so low. Having said that, there are a couple of centres that have surgeons that are very skilled in this area. So lack of evidence doesn't always mean you shouldn't do something, but we don't have the evidence for optic nerve sheath fenestration at the moment. Just
one last question from me. Posture, posture and, sitting position and on the side. What's the range of the pressure? How do you adjust it? Yeah, that's a good question, Fire. So actually, James Mitchell's just been finishing up his PhD, where he has had telemetric ICP monitors placed in a number of patients with IIH, and he's been looking just at that question. And in a nutshell, it's about a 50% difference between a supine position and a sat position. And it doesn't make any difference if you're sat or if you're standing. But if you lie down compared to sitting up, it's about 50% difference. And then once you're lying down, it's about a 5% difference or so between if you're in the lumbar puncture, curled up left lateral position compared to lying on your back, fully supine. So there are differences, and it is, I think, going to be increasingly important to think about how we interpret pressures in the setting of how the patient is positioned. And we are moving not to doing a lot of telemetric monitoring, but we are using a lot more for very, very complex patients, patients with optic atrophy, patients who have Chiari and we can't do lumbar puncture, patients with shunts and shunt blockages where we're questioning if these are normal pressures or low pressure headaches or
or if it's nothing to do with them, the pressure that they're getting headaches. So we are using telemetric monitoring a lot more. And in that situation, the position of the patient and how long you monitor for is absolutely crucial, because we also see that even within a 30-minute period of lying down, your ICP significantly rises. So how long the patient has been lying will affect your ICP reading.
Great, great. Thank you very much, Alex. We're really sorry to disturb you on your short break to the Lake District, but thank you very much for chipping in. Susie, that was a wonderful talk. I thoroughly enjoyed it. And Ben, looking forward to collaborate with the Birmingham people with this stenting versus shunting. Thank you very much, ladies and gentlemen. And we thoroughly enjoyed it. And it is available in YouTube within a few days. So look forward to seeing you again next month. Thank you very much once again to the panelists, and thanks for all the audience to be here till the last minute. Thank you.
Thank you, Fayez. Wonderful to have it hosted. Thank you for the opportunity.
Thank you.
Thank you very much, Fayez. Thank you.
Good night.
Good night.